A very good afternoon and a warm welcome to one and all to a brand new edition of Believer Students Clinic at BCMCH today. This is a part of the vertical integrated undergraduate virtual classes on Zoom platform from Believers Medical College Hospital, Pathanamthitta, Kerala. As you all know, the attendance for these undergraduate clinics is regularly uploaded to the university. We all know that you had a fantastic MedFest last week. Congratulations, it was really world class. Again, you did well for the HIV and the AIDS quiz contest. That too was indeed commendable. Congratulations to all the students. Well done indeed. Today and on Saturday, we have two presentations which are emergency medicine topics. As for the usual classes, we request the students and attending faculty and esteemed audience to please make this class an interactive session by posting questions in the chat box. Please answer also in the chat box within 2 seconds if a question is asked by the speaker. So students, on your mark, get set, here we go. The topic for today is burns. The first presentation for today is by the Department of Plastic and Reconstructive Surgery, which will be followed by a quiz on burns by the emergency medicine team. This session will be chaired by your favorite sir, Dr. Abraham Matthew, Associate Professor of Surgery. May I request Dr. Abraham Matthew, sir, to say a few words on this topic.
Thank you for your welcome. Good afternoon, students. I am very much happy to moderate the session of a very important topic, which is both for your theory exams as well as for your future career. You will be encountering patients who are suffering from this dreadful condition, as you will be learning by our most expert consultant in burns treatment, Dr. Deepak Arvind, as well as our efficient doctor who is in the emergency, Dr. Sugit, will be taking you through a very lively session. And this is, from an exam point of view, this is a very important theory question for your exam, as well as any of you who are trying to work as an interest in emergency medicine. You cannot leave out this topic in for all cases related to burns, and the different aspects of the management of burns is a very important subject. And with this introduction, I invite Dr. Deepak and Dr. Sugit for the session. Thank you.
So that's it. Let's start. Coming to the first class on burns by our young and dynamic senior consultant, plastic and reconstructive surgeon, Dr. Deepak Arvind. Dr. Deepak Arvind is working in Believers, has over 9 years experience in this field. He did his MBBS from Pariyar Medical College and MS in surgery and MCH in plastic surgery from Trivandrum Medical College. He has worked as AP in KMCH and as consultant in Mata Hospital, Kottayam before joining Believers. His areas of expertise include microvascular surgery, reconstructive and cosmetic surgery, especially after maxillofacial cancer resection, and aesthetic surgery after burns. Handing the mic to Dr. Deepak Arvind. Over to you, sir.
Good afternoon, students. Actually, burns per se is a topic which is often not covered in detail during our undergraduate days. And there are a lot of confusion and misconceptions regarding the right management of burns. At the MBBS level, we need to know the basic pathophysiology, anatomy, and the basic management of uncomplicated burns. So I would be dealing with mostly regarding the basics over the next 30 minutes. So there are plenty of myths and misconceptions regarding the management of burns. of which the most important and most commonly encountered one is regarding first aid. You might have heard even now, most of all the patients who come here give a history of having applied white toothpaste soon after burns, which is not supported by any scientific evidence. And other things which are commonly used in our state are butter, kolinai, ghee, honey, murvanna, egg white, etc. So whether these are all useful or not, at the end of the session, you should be able to answer. Another common myth is pouring water, does it lead to blisters? Then which dressing is better, either an open or a closed? So can we apply ice directly to burns? Then when you see blisters, should you break it or not? Then people often ask whether there is any special oils, creams to avoid scars. Then what is the role of these all sorts of proprietary creams like Silverex, Burn All, Burn Heal, etc.? Do they really help? Are there any diet restrictions after burns? Then very commonly asked question to me by my patients is any risk of scar. After every burn, they ask whether the scar will hypertrophy, whether there is any likelihood of hyperpigmentation, etc. And lastly, what is the need for plastic surgery after burns? So what I intend is at the end of this session, you should be able to find a right answer for all these questions. So quickly about just the basic skin facts. As you all know, it's the largest organ. The thickness varies from thinnest at the eyelids, where it's only 0.05 millimeter thick, to the thickest found in the palms and the soles, where it's 6 millimeter thick. Skin comprises 1/6 of total body weight, and in an adult male, the total area is around 1.7 meters square. Main functions of the skin being thermal regulation, prevention of fluid loss, and it's a barrier against infection and also a sensory organ. Quickly about the anatomy, basically there are two layers. The upper layer is the epidermis and the lower is the dermis. The upper third is the epidermis, and the dermis has two layers. The upper part of the dermis is the papillary dermis, and the lower portion is the reticular dermis. What you have to know is that it is the reticular dermis which mainly contains the dermal appendages. They are the sebaceous gland, the sweat glands, the hair follicles, etc. And the nerve endings and the blood vessels, capillaries also end in varying level in the dermis. So this basically the burns are classified based on the depth of involvement in the skin. So they are classified as first degree, superficial second degree, deep second degree, and a third degree. Previously, there was a fourth degree, but nowadays only this is the standard classification. First degree burn is the one which involves only the epidermis. Superficial second degree involves the upper dermis, otherwise known as the papillary dermis. The deep second degree involves burn depth up to the reticular dermis. Third degree is involvement of full thickness of the skin and anywhere and any depth below. Previously, muscle and all was considered as a fourth degree. Now, anything beneath the subcutaneous fat deeper is known as third degree only. So, few features about each degree. First degree, it will be red and the area will be extremely painful. A classical example is a sunburn. In our population, we rarely come across a first degree burn. Here, there is nothing much to be done. Usually, it heals within a week without any scarring. So, superficial second degree is otherwise known as a superficial partial thickness burn. This is the most commonly encountered burn we see in practice. The characteristic finding is a blister. Usually, it appears few hours after the accident and it keeps on increasing. And once the blister, the roof is removed, the wound can be, the bed is found to be blanching. And redness, it will be red or pink. And pain is also extreme in a superficial second degree burn. What you have to do is, if it is in a hospital setup, you have to do a debridement of the blister and apply some mild topical antibiotic followed by a covered dressing. And usually it heals without any scarring and in less than 2 weeks. That is very important. If infection doesn't occur secondarily, it heals within two weeks and there will be no scar. A deep second degree is otherwise known as a deep partial thickness. Here also you can find blisters, but after removal of the roof, the floor will be more pale or slightly white. Sensibility will be reduced and there won't be that much pain as a superficial second degree and the blanching will be absent. Here also there is a tendency to heal, but healing might get delayed it might extend up to 3 to 9 weeks. And since the deep dermis is exposed here, the healing will result in a scarring. And if the wound takes more than 3 weeks to heal, usually it results in a hypertrophic scar. So in these cases, if the healing is delayed more than 3 weeks, it's better to do a early excision and skin graft. Third degree burns is otherwise known as a full thickness burns. They involve all layers of the skin and any layer below. Here usually pain will be absent or very mild because the nerve endings have been damaged, and the lesion looks like a white or a charred black color, and the tissues are leathery and hard. Here the dermal appendages have all got destroyed, so there is no chance of primary healing. It won't heal by itself by epithelialization. If you don't do a surgical, that is, if you don't do skin grafting in these cases, there will be healing by secondary wound contraction, and what results is a post-burn contracture. So in any third degree burn more than 1 centimeter, the ideal management should be tangential excision followed by a skin grafting. This slide is very important. To know the pathophysiology of burns, it was classified by Jackson. It's known as a Jackson zone of injury. This is a 3-dimensional concept. That is, there are 3 zones in any area of burn, and the central area is known as the zone of coagulation. That is the area of irreversible damage, where there is permanent tissue depth. You cannot save that area. The zone just surrounding it is known as a zone of stasis. This is the potentially salvageable area, where with an ideal first aid and an aggressive resuscitation, you may be able to salvage this area and convert it to a zone of hyperemia. The outer zone is the zone of hyperemia. There will be vasodilatation and increased blood flow. This area will heal normally without any scarring. So what we aim to achieve is, with an aggressive first aid and IV fluid resuscitation, you can convert some areas of the zone of stasis, which can be converted to a zone of hyperemia. So what are common physiological changes in burns? Soon after a major burn, there are release of inflammatory and vasoactive mediators, which result in increased local and systemic capillary permeability. So there is translocation of the protein fluid from the intravascular component into the third space or the interstitial space, and that is the reason for edema. So this keeps on increasing. When the burns area extends more than 25%, edema also develops in other areas like lung, muscles, and intestine. So unless this intravascular volume is rapidly restored by a very aggressive IV fluid resuscitation, patient will go into severe shock, which is known as a burn shock, and this can lead to death. So the maximum intravascular hypovolemia and edema peaks around 8 to 12 hours. So once the burn occurs, the next 12 hours is a period when this keeps on increasing. And burn shock can lead to critical hypoperfusion and end organ damage. So what is our aim of the initial aggressive fluid resuscitation is to maintain tissue perfusion to end organs and to prevent the damage. So what are the types of mode of burn injury? So burns can be due to thermal energy, chemical energy, electrical, or radiation. In this talk, I am basically talking about thermal burns, which is the most common mode, and just 2 or 3 slides about electrical burns. Chemical and radiation, due to paucity of time, I am not dealing with. So thermal burns can be due to flame, that is due to a dry heat, or all burns due to moist heat or liquids are known as scald, which are very common in the pediatric and elderly population. Electrical burn, you just need to know what is a high voltage burn. Their classification is any burns due to voltage more than 1000 volt is known as a high voltage burn. So a few points about scald. This is very common in children, very common. In patients presenting in our hospitals, at least 40% of burns occur in children who present here. So the depth of the injury usually depends on the temperature of the water, then the thickness of the skin, and also the duration of contact. Just to cite an example, water at 60 degree can cause a deep dermal burn in 3 seconds. But just by increasing 10 degree, the same level of injury can occur in 1 second. So the temperature is equally important, and also the duration of contact. Boiling water generally causes a superficial or deep dermal burn, depending on the duration of contact. Hot oils are actually dangerous. They usually lead to deep dermal or a third-degree burn. Few slides about electrical burns. What is high voltage is known as more than 1000 volt. That usually occurs in usually a work-related electrical burn that is seen in this KSCB workers, etc. Or accidentally when our people try to climb or cut trees or cut coconut, etc. They accidentally touch the electric post, etc. So extensive skin injury is seen, and with necrosis at the contact point and also in a deeper structures. Electricity usually flows through the body tissues and it generates heat. So the more the resistance of the tissue, it generates more heat and more tissue damage. So there is always a risk of increased multi-organ injury. So why it's important is degree of actual tissue damage is much more extensive than what you see at the initial examination. In electrical burns, you have to always look for any contact wounds, that is at the entry wound and the exit wound. Extensive soft tissue damage can result in compartment syndrome. That is very important. If you suspect a compartment syndrome, you may need to do a emergency fasciotomy to release the tension. Muscle necrosis can lead to severe myoglobinuria, which can result in an acute renal failure. So electrical burns are also prone for cardiac arrhythmias like atrial fibrillation, supraventricular arrhythmias, etc. So whenever there is a major electric burn, we always get an initial ECG done from the ER. And if there are any variations seen, a continuous ECG monitoring for the first 24 hours is recommended if there is any variation in the initial ECG. So this is a picture showing a high voltage burn. This is a 11 kV line the patient accidentally touched while trying to pull down a coconut. So he developed extensive burns on the first web space. There is extensive tissue necrosis. The second picture shows the thigh, where also there is a deep burn. This is his shin actually. Here a part of the bone, tibia, is also exposed. These all pictures are from the same patient. This is the extent of damage in a high voltage burn. So these sort of injuries will require multiple surgeries and flap cover, skin graft, etc. This is another example in another patient showing a electrical burn and deep tissue injury in the right thigh. So let me go through a few clinical examples of the various degree of burns. This is a classical first degree burn. Very rarely we come across in our population. It's only seen in Caucasians. So classical example of a superficial second degree. Here you can see the blisters. This is a child actually presented usually around after the next day only, around 24 hours. So the blisters and the lid edema has developed. But just with topical dressings and ointments, actually after a week, 1 week later, most of his burn wounds are healed. That is because it was just a superficial second degree involving only the papillary dermis. So the child, you see the same child 1 month afterwards, there is actually no signs of a burns. It has healed well by re-epithelialization. Another case of superficial second degree. The outer blister skin has been debrided while the patient is seen in the ER. Here some areas are showing deep second degree. This is a mix of superficial and deep second degree. This is another patient who developed extensive burns. So after this is picture you see is after debridement of the outer blisters and the skin. This most of the areas were superficial second degree, and this healed without scarring in 2 weeks. So this lady, 60-year-old lady, had presented to us 3 weeks after, around 19 days, around the 19th day, following an accidental flame burn. She had developed extensive burns, but she was treated in a local hospital with just open wound and just the application of ointments. But actually she had sustained a deep second degree and third degree burns of some areas. Here the breast also has a third degree burn. This has a charred or a hard appearance. And what we had to do when we saw the patient, she was already going into sepsis. So she underwent extensive debridement, skin grafting, etc. This is a case of a lady who accidentally dipped her hand in a hot oil. She was working with a catering unit So her hand fell into a very boiling oil and she developed severe burns. You can see the tip of the fingers have almost undergone necrosis. So here is the area of extensive burn. So while she had presented, it was very tense. So we did this is known as a escharotomy. We had just released the tension. Then proximally you can see areas which are of the deeper second degree, and much proximally is superficial second degree. So the same patient is showing different degree of burns. This is a usual pediatric patient who presents with hot milk falling over the hands and the upper chest. Most of the blisters have been debrided and most of the areas look like a superficial second degree. Patchy areas of maybe deep second degree are also there. This is another girl child, a 6-year-old child, again scald burns. This is at the time of birth. You can see few blisters, but some area, this area looks more paler. So this looks like a deeper second degree. And this is after 2 weeks. Most of the other areas have healed except this 2 or 3 areas, which healed, which usually took around 3 to 4 weeks to heal completely. This patchy areas. Another man who accidentally fell on a burning wood and he developed extensive burns. So this is a classical picture of a 3rd degree burns or a deep burn, a charred and a pale appearance. Again, here in this picture, you can see the thrombosed subdermal veins. So thrombosed veins are another finding you see in a deep burn. It's also an example of a 3rd degree burn. So superficial second degree burns, if managed properly with just topical antibiotics and a covered dressing, usually they heal within 2 weeks and without much scar. This is the same person after 2 weeks. This is another picture showing, this is a picture at presentation. 2 weeks afterwards, new skin has started to come. The defined dots you see are the reepithelialization. And usually this pigmentation is complete by the whole, to be complete, it takes usually around 4 to 6 weeks. This is another child with scald burn. Here we have applied a collagen dressing, which is a temporary skin substitute, a biological dressing which gives an environment favorable for healing. That can help in the healing. And by 2 weeks, this is healed very well. And now the reepithelialization usually gets complete by around 6 weeks. So what will happen if these deep second degree burns are managed with wound dressings alone? And some people say we'll wait to heal. The final result usually will be a hypertrophic scar, which later is very difficult to heal. So what happens in 3rd degree burns also, sometimes they are also managed conservatively. Patients won't be willing for doing a skin grafts, etc. They keep on doing the dressing and it takes months to heal. And the end result will be post-burn contractures, which are actually functionally and cosmetically disfiguring and difficult to treat. What is a hypertrophic scar is usually seen in deep burns. Then complete healing takes more than 3 weeks. This 3 weeks is actually a very important time. If any burn wound, you can make it heal by 2 weeks, there will be absolutely no scarring. And up to 3 weeks, you can wait for healing. Usually they don't go for scarring. Any burn wound which takes more than 3 weeks is highly prone for hypertrophic scarring. Usually these scars following burns are very pruritic and inelastic. And when you don't treat the scars, what happens is later again collagen deposition undergoes and finally it ends up with contractures, which are a cause for functional as well as cosmetic disfigurement. So here this picture I had shown earlier, some patchy areas, there were deep second degree areas, which ideally should have been skin grafted, but the parents were not willing to do a skin graft at the end of 2 weeks to 3 weeks. Finally, the child came after 2 months with hypertrophic scar. This is found in exactly the same areas where she had deep second degree burns. This is another girl child, 6-year-old child, again back of the trunk, where she had actually developed varying thickness. Some areas were superficial second degree, upper part that has healed well. The deep areas took around 6 weeks to heal. So it has resulted in a hypertrophic scar. This is another 4-year-old male child. He accidentally fell into a hot basin with hot water. That is why both his buttocks were burned. They came from Alleppey around 2 months after the burn. They were being managed by a pediatrician, their family pediatrician. He had advised just to continue the dressings, reassuring them that it will heal. Finally, it took around 2 to 3 months to heal, but the end result is a hypertrophic scar. And this condition is very difficult to heal, to treat now. So these are the examples of post-burn contractures. Again, if you don't intervene at the stage of post-burn scar, or if the third-degree burns are left to heal by itself, it will result in very bad scars, very ugly and functionally problematic scars. Here the lower lip is scarred and contracture has pulled it down. The neck is also has a flexion contracture. This is another case, a severe contracture of the lower lip, neck, and here also axilla. Once the patient develops these debilitating contractures, it is very difficult to treat. You might need multiple surgeries to release them and then put skin graft, followed by long periods of rehabilitation. This is a 10-year-old child who, after an extensive burns, you just can see that there is an ectropion of the lower lid due to the scar pulling down. Then there is a severe eversion of the lip. Then the neck has been, you can't see a neck here. And both axillas have developed contracture. This child had developed a deep second degree and a third degree mostly. Burns which are just managed with dressings alone, which took like 3, 4, 5 months to heal. So this is the end result. Now he'll have to undergo multiple surgeries, at least 4 to 5 in stages. And you will never be able to attain a near perfect result. So total body surface area is the best predictor of prognosis in burn. And the simplest and the most common rule to calculate a body surface area is known as the Wallace rule of 9. Here one thing is you should not consider any first degree burn, only the second degree and third degree are counted. So in children and all where you need accurate measurements, the London Browder charts are available. They give a very accurate and specific measurement. So when there are small areas are burned, like for example a small area of the thigh or the hand, how you measure is the palm, the adducted palm of the patient's hand you can take as around 1%. That is how the area is calculated for a small burns. This is the Wallace rule of 9. The whole body is divided into 11 areas of 9. So the whole head and neck is 9%. Front is 4.5, back is 4.5. Upper limb, front is 4.5, back is 4.5. Chest, front and back 9. Abdomen, front 9, back 9. Lower limb, each lower limb, front is 9, back is 9. And the perineum is 1%. This is how 11 into 9, 99, plus 1% perineum, 100%. But in children, it's slightly different. Why? Because in child, according to the growth of the child, the proportion of the head to the body is different. So in an infant, you see the head forms usually around 1/5 of the total stature. So the head occupies more area, like 18% is given to the head, whereas in adult it is only 9%. Where you have reduced it is in the limb. The limbs usually in an adult, each limb is 18%, but in a child, that area has been reduced and more area has been given to head. So as the child grows, you reduce the surface area from the head and more is given into the lower limb. So for accurate measurement, you will have to use the London Browder chart. Here, according to each age and each area, you can look at the chart and make a correct calculation. What are the reasons for death in burns? More than 50% deaths occur usually in the first 5 days. Early death, the most important cause is burn shock. The pathophysiology I have told before. Another important cause is an inhalation injury. Cause of late death is usually infection, that is resulting in septicemia and multi-organ dysfunction syndrome. So why inhalation burns are important? Because it is an important cause of early death. Always you have to suspect whenever a patient comes with a history of burns in a closed space room after a road traffic accident, in a motor vehicle accident getting burned. Then when you see the patient, if there is burning of the hair, facial burns, singed nasal hairs, the eyelids have been burned. Then when you see carbonaceous sputum, perioral burns, these are all warning signs where you should suspect an inhalational burn. Because there are 3 effects of inhalation burn. The upper airway burn will result in edema and can cause laryngeal obstruction. Second is carbon monoxide poisoning, because carbon monoxide has 250 times more affinity for hemoglobin. And when there is more than 50% saturation, it results in neurotoxicity and subsequently death. Treatment is simple. Diagnosed early, the treatment is giving 100% oxygen by mask. Another reason effect is due to the chemical pneumonite used due to the toxic gases. So this one important area which we should be thorough is regarding first aid in burns, where you have to give the right advice. And this is one area where most of the people in our society still don't have a definite idea. First of all, ensure your own safety. Then second step is to stop the burning process. So if the patient is burning the clothes, and don't ask a patient who is in flame burns, don't ask the patient to run. It will actually increase the flame. So we have to stop the burning process by ask the patient to drop on the ground and roll. Or if there is a blanket or anything available, you can cover the patient and stop. In an electrical injury, always disconnect the person from the source of electricity with a non-conducting object. This is the single most important thing. Start cooling the burn area immediately, as early as possible, with normal running tap water or any lukewarm water, or even cool water is fine. Never place ice. Ice should never be directly placed on a burn wound. And this cooling with water should be done for a minimum of 20 minutes. Wherever you go, the recommendation is same, at least 20 minutes. How this helps is because once the reason or the cause of the burn has been removed, there is some amount of transferred heat at the area of burn. And the transferred heat is causing damage to the microscopic damage to the skin. So if you start cooling immediately, the extent of the damage can be reduced. In case of chemical burns, the flushing with water should be continued for more time. So the best option is always available at all places is normal. You can show the hand or leg can be shown under a tap water, under a tap. Then if it is fallen in your chest or abdomen, best way is to go and stand underneath the shower again for at least 20 minutes. So in children, you can actually immerse the child. If it has fallen onto his thighs or legs, you can immerse the child in a small bucket, etc. Always other methods, like you can continue flushing with a hose. You can stand, take water in a big bucket and even immerse your leg like that. So always remember, first water after any burns. All the rest should be done later only. Other things we have to take care is avoid hypothermia in all major burns. If the burns is involved a major area, always cover the patient with any warm cloth. Try to remove all this jewelry and clothing. Why? Because this jewelry and all, after like 12 hours, the patient will develop severe edema. Then all these rings, bangles, etc. can cause constriction and vascular compromise distally. And the best way in the outdoor setup or at home is to cover the burn with any clean cloth. After doing your first aid, best way is to clean it with a dry, clean cloth. You can avoid applying any sort of ointments or topical preparations at home. There is actually no need to apply anything in the first 24 to 48 hours, as the wound bed is usually sterile in the first 24 hours. And if the patient complains of pain, you can give some analgesic like paracetamol or ibuprofen. And if the burns has involved the limbs, always raise the limbs. That will help to decrease the edema. In case of the face, ask the patient to sit upright. So what are the indications or the criteria for hospitalization? This is a very important chart which we should understand. So any child with more than 10% surface area burn. All burns means that this includes only second degree and third degree burns. Never consider first degree injuries. So any child with more than 10%, any adult with more than 20%. So that is very easy to remember, 10% and 20%. And when in full thickness burns, that is full deep burns, charred appearance, even more than 5% is an indication for hospitalization. Then burns of special areas like face, hand, feet, genitalia, etc. So whenever you suspect inhalational injury, again, that is an indication for admission. Then major electrical burns, that is more than 1000 volt. Severe other medical comorbidities or other associated injuries, again, is an indication for hospitalization. So what are the emergency room management? I'll just brush through. As usual, first and foremost is look for airway, breathing and circulation. That involves a very quick primary survey, followed by a secondary survey later while you have started the resuscitation. ABC, you all know, first look for all the basic airway, breathing and circulation. So in ER management, actually if the patient has come without doing an ideal first aid but has come to our ER within the first 30 minutes, it is always beneficial to cool the burn. That we have initiated in our ER, it is continuously being done like that. Yeah, they have been told like that. Most of the patients, sometimes they come within 15 minutes and all. They might not have done an ideal first aid. So only after continuing the first aid for at least 30 minutes, we need to do any other management. So when there is a suspicion of inhalation burns, always start 100% oxygen. And if there is suspicion of some airway compromise like laryngeal edema or patient is having respiratory distress, it is better to intubate the patient in the ER. Always in major burns, more than 10 to 20%, it is best to put a IV cannula, preferably a large bore one like 16 gauge. Because as you lose time, edema sets in and it will be difficult to cannulate. So there is another doubt always whether you can put a cannula through a burned area. Yes, it is advisable. You can place a cannula through a burned skin because that area is sterile. So in the meantime, always document weight because that is important in calculating the Parkland formula. So in major burns, you might need to start IV fluids and always start ringer lactate, which is the IV fluid of choice in the first 24 hours. In major burns, more than 25 to 30%, you might have to insert a Ryle's tube. And also Foley's catheter is mandatory in all patients requiring a IV fluid resuscitation. That is to monitor the urine output. And regarding covering the wounds. So covering the wounds usually during the 24 hours, actually we needn't, definitely you don't need to apply any antibiotic ointment. But in our setup, we apply some mild ointment, which should be colorless, like a Neosporin, Fusidin, or something like a Megahil gel, etc. These are all mild antiseptic topical ointments, which give a slight soothing effect. But in the initial 24 to 48 hours, actually there is the wound is not infected. So after applying an antibiotic, always you have to keep a non-adherent gauze dressing. That is something known as Gelonet or Bactigras, over which you apply sterile gauze and do the dressing. Why this is non-adherent dressing is kept to decrease the pain while removing subsequent dressings. So wrap the patient in a thermal blanket if it's an extensive burn. Always don't forget to elevate the limbs because as time passes, the limb edema will increase if you don't do limb elevation. And for deep burns, always TT injections are advised. So this is another temporary biological substitute known as collagen. This also gives a temporary wound dressing. It actually gives a favorable environment for healing. This is usually removed by around 5 to 7 days. This is how this picture I had shown earlier. This is how after dressing the wound will look like. We have done a dressing with paraffin gauze followed by a sterile dressing, Gamgee pad and a ocean. Fluid resuscitation, what is the goal is to re-expand the reduced volume to restore the cardiac output and to improve an end organ perfusion. What is the indication for doing an IV fluid resuscitation? Any child with burns more than 10% and any adult with burns more than 15 to 20%. For ease of remembering, you can remember as a child more than 10% and adult more than 20%. It is similar to the one like hospitalization also, any child with burns more than 10 and adult more than 20%. So if the patient can tolerate oral fluids, always oral fluid resuscitation is preferred over IV fluid resuscitation. But if the area is a big area is burned, we need to instill the fluid. We have to replace the fluid fast, for which we do a IV fluid resuscitation. So that there are many formulas to calculate the fluid requirement. This point is important. Maximum fluid shift occurs in the first 8 hours and thereafter it slows. So fluid replacement should be very aggressive in the first 8 hours. Most widely used formula is known as the Parkland formula, which is used to calculate the total volume of fluid to be given in the first 24 hours. 4 ml per kilogram per percentage body surface area. So the total ml you calculate and the half of which you have to given in the first 8 hours after burn, not after coming to the ER. And the remaining half is given in the next 16 hours. So colloids are usually given after 24 hours. Most important criteria to evaluate adequacy of fluid resuscitation is to look for the urine output, which usually you have to maintain at 0.5 to 1 ml per kg per hour. So this is a classic example of a 60 kg adult who comes with 30% burns to a ER at 6 p.m. but the burns had occurred at 2 p.m. So how do you calculate 4 into 60 into 30? That is 7,200 ml or 7.2 liters. For ease of calculation, take it as 7 liters. 7 liters is 14 bottle of IV fluid. So half of this is 7 liters. 7 liters should be over by the first 8 hours. So that 8 hours should be calculated from 2 p.m. and not from the time the patient is seen in the ER. So 2 plus 8 hours will be up to 10 p.m. So you only have the remaining 4 hours to finish off this 7 bottles of ringer lactate. And the remaining half you have to give over the next 16 hours. So what is importance of nutrition? Major burns always it ends in a hypermetabolism, and there is protein catabolism. More than 25% burns hypermetabolic response. The body's basal metabolic rate is increased to up to 200%, and calorie needs can also rise up to 5,000 calories. So without any nutritional support, if there is more than 40% burns, the patient will lose up to 1/4 of his weight by 3 weeks. And there is always immunosuppression also in major burns. So objectives of a nutritional management for all major burns more than 20 to 25%, you have to give some nutritional support. Proteolysis is the classical hallmark of a major burn. So the protein intake has to be almost double. Normal protein intake comes to around 1 gram per kg per day in adults, which has to be increased to around 2 gram per kg per day in adults. In children, you need even more. You have to increase up to 3 gram per kg per day. High protein diet has to be advised. Mainly non-vegetarian food, and vegetarians can consume more of soya-based feeds. So actually there are no diet restrictions after any burn. Some people ask whether you can drink milk, whether you can take egg, etc. There are no diet restrictions after any burn. Then all these trace elements and vitamins like A, C, which are required for normal healing. So what is the role of any role for early surgical intervention in burns? This is known as escharotomy, fasciotomy, and escharectomy. So escharotomy is the one I showed a deep burn where the patient had come with a severe deep burn with a tense hand, where you had to you did a small incision over the hand. That is, you put longitudinal incision to release the tension. Then there is circumferential burns of the limbs or of the chest. To release the tension, you do something known as, with a knife, you just score. That is known as escharotomy. Fasciotomy is in deep burns, like in electrical injury and all. When the deeper tissues have been damaged, there will be a rise in compartment pressure, and compartment syndrome can occur, where you have to do an early fasciotomy to increase the perfusion. Then this is known as tangential excision and skin grafting. This is the treatment of any deep 2nd degree and 3rd degree burns. So what is the role of plastic surgery? Again, early tangential excision and skin grafting is done for deep 2nd degree burns which are not healing by around 2 to 3 weeks. And all 3rd degree burns will require excision and skin grafting. Usually we do it around 2 weeks. So deep burns with exposed vital structures, the skin grafts won't take. Like if the bone is exposed or tendon is exposed, there you will require what is known as a flap coverage. Then when patients who present late with sequelae of burns, like post-burn scars, there also you have to do small scar revisions, plasty, etc. When the patient presents with post-burn contracture, you have to do a contracture release and skin graft or flap cover. So finally, this is in a nutshell about the basic management. So the initial slide I am just repeating. So after this talk, have you got the right answers to all these questions? Let me go one by one. First aid, the ideal first aid, world over, there is only one first aid, that is running, should show the burn underneath a running tap water or lukewarm water, minimum 20 minutes. Pouring water causes blisters, never. It is a misconception. Open or closed dressings. Nowadays, the recommendation is a closed dressing. What are the advantages of closed dressing? One, it decreases pain. There is less chance of secondary infection, and it gives a moist bed which favors healing. So can you apply ice directly over burns? Never. Never apply ice directly to burn skin. It will result in cell death or a cell death due to intense cold. Can you break the blisters? No, if at home, because trying to break the blisters at home will leave a unsterile environment and you increase the chance of infection. If the patient is seen in the emergency room or in the hospital, we can do debridement of blisters using a sterile technique. So are there any special creams or ointments to avoid scars? No, they are just advertisements. Silverex and other topical antibiotics, in the initial 24 hours, actually there is no need for any such preparations to be applied. But if at all you want to apply, we prefer a very mild anti creams like Neosporin, Fusidin, Megail, etc. These are Soframycin, etc. Silverex is a very potent antibiotic which is indicated only in deep burns and infected or likely to be infected wounds. You needn't apply Silverex to any burn wound which persists to you, especially in the first 24 to 48 hours. And in children, it even causes burning sensation. And never apply colored ointments like betadine because it interferes with our assessment of the wound depth. So are there any diet restrictions? No, there are no diet restrictions after a burn. So what is the possibility of hypertrophy of a scar and hyperpigmentation? Yes, if your deep second degree and third degree burn, if you don't intervene surgically and put a skin graft, there is a chance of it later developing a scar hypertrophy contracture. Hyperpigmentation is also very common in our population. Then what is the need for plastic surgery lastly? Because in deep burns, deep second degree and third degree burns are the ones which need a excision and skin graft. And in rare cases, flap cover. When patients presenting late, like with contractures and scars, etc., you have to again do a treatment like skin graft and other flap cover. So these are the important aspects about burns. So thank you all.
Thank you, sir. That was indeed a unique and detailed presentation. We'll take the questions to Dr. Deepak Arvind, sir, at the end of the session. Next on the agenda is a rapid fire quiz on the topic burns. Welcoming one and all once again for the rapid fire quiz on burns. This quiz will be conducted by dear Dr. Sujit Joseph. He is the live electric wire, the very heart and soul of our emergency department. Sir handles life and death issues daily with his left hand. Dr. Sujit Joseph did his MBBS from Father Mulla Medical College, Mangalore. He did his PG in MEM. He also has an additional degree of MRCEM. He is currently working as a junior consultant in our emergency department. We request the students and attending faculty, audience to please make this class an interactive session by answering within 30 seconds in the chat box.
Good afternoon, everyone. I'm Dr. Sujit Joseph. So I'll be asking 3 questions on burns. So you will be given 30 seconds for each question. So let's start. Okay. Coming to first question. As a patient admitted with burns over left thigh, skin looks leathery white with no blisters or pain. How is this burn categorized? Option A, superficial burns. B, partial thickness. C, D, partial thickness. D, full thickness. Most of you have answered C, but it is, you can notice, except Atira, Cecil Kumar, Fasna, Achu Joseph have answered as D. That is full thickness burns. You can see there is leathery white appearance, no blisters, and patient doesn't have any pain. And so these are the classical features. As are explained, it will be involving. Here you can see in the full thickness burn, epidermis and dermis will be involved. It will be dry, white, or leathery, and there is no sensation due to restriction of the nerve fibers. It requires graft or flap. Okay. Coming to next question. Which finding is specific for carbon monoxide poisoning in a victim of house fire? A. Expiratory stridor. B. Carbonaceous material in the sputum. C. Cherry red color of the mucous membrane. D. Pulse oximetry showing 90%. Yeah, then. C. Okay. Okay. So the answer is cherry red color of the mucous membrane. So most of you answered correctly. It's a simple question. Cherry red color of the mucous membrane is because of the presence of high levels of carboxyhemoglobin in blood. It is seen in only 2 to 3% of symptomatic cases. Have you confirmed it is by measuring carbon monoxide COHB levels in ABG? More than 10% COHB levels should be managed initially presenting with headache. As higher it goes, like about 20, 30, you will be, the severity increases. The next question. Which is the ideal fluid for burns resuscitation? Linolactate, normosaline, DNS, MSL. Okay, it's a direct question, simple question. Okay. So answer is Linolactate. Okay. So briefly, crystalloids, Linolactate is a crystalloid which have small molecules. They are cheap, easy to use, and provide immediate fluid resuscitation, especially in ER management. Colloids have larger molecules. They are costly and may provide swifter volume expansion in the intravascular space, but it may induce allergic reactions, blood clotting disorders, or kidney failure. Few of the examples are in crystalloids, normosaline, Linolactate, 5% X dose. Coming to colloids, human albumin, gelatin solutions like Hemacil or Gelafindin, Dextan, and hydroxyethyl starch. Okay, moving to the next question. All of the following are lab test results of a patient presented to ER with extensive burns. Which results should the nurse report to the physician immediately? Is it serum sodium level elevated to sodium level of 131, serum potassium of 7.5 millimoles, arterial pH of 7.32, hematocrit of 52%. Majority have answered as B, that is right. That is hyperkalemia. Hyperkalemia can result in more than 5.5 milligrams can result in arrhythmias like VF, VT. So immediate correction for hyperkalemia has to be started as soon as the report is put in the result. Okay. Next question. The patient has experienced an electrical injury with the entrance site on the left hand and the exit site on the left foot. What are the priority assessment data to obtain from this patient on admission? Anjali Muti. Okay, option A, airway patency. B, heart rate and rhythm. C, orientation to time, place, and person. D, current range of motion in all extremities. Everyone is?
B.
Okay. The answer is correct. B. We have to look for electric shock can cause direct damage to myocardial tissue, and it can cause cardiac arrhythmias. Most common arrhythmias are asystole or ventricular fibrillation. Question. 54-year-old male patient with history of heart failure following antirevolumide was brought to ER with 30% burns, which one of the following conditions should alert the nurse to the need for alteration of fluid resuscitation plan? Is it seasonal asthma, hepatitis B 10 years ago, MI 1 year ago, kidney stones within the last 6 months? Okay. There is mixed response for C and D. Okay. Okay. Answer is C. Resuscitation for burns management in especially heart failure patients should be closely monitored. They can develop pulmonary edema due to fluid overload. So next question. In the case of a thermal burn to the skin, how should the affected area be treated? Wash with soap and water, use cool ice, apply oil or butter, flush area with running water for at least 20 minutes.
No, that's the previous answer.
And previous answer. Answer D and now. Okay. That's the direct question. Okay. Answer is D. So treat burns with cold or lukewarm water at least for 20 minutes. Evidence suggests that this can reduce pain and edema, reduce the depth of the burn, decrease the overall inflammatory response, improve the speed of wound healing, and minimize scarring. So coming to the next question. Electrical burns can be caused by household current, certain batteries, and lightning. What should be done first after a person has an electrical burn? Cover the burned area with blanket. Be sure that the person is out of electrical supply. Put ice over the area of contact, not the above. Okay. Answer is B. Most of you have answered correctly. Be sure that the person is out of electrical supply and use a non-conducting material to detach the electrical supply wire or any conducting material. Okay. Early management of for a patient presenting with more than 20% burns are all except. Is it analgesics, application of silver sulfadiazine, IV fluids, use a non-adherent dressing, administration of O2 in case of house fires? B, E and B. Okay, majority have answered as B and few has answered E. Okay, answer is B, application of silver sulfadiazine. Silver sulfadiazine, it may delay wound healing and requires more frequent dressing changes. It creates a pseudo scar around the wound that can also result in microbial colonization. Which of the following statement is false? Administration of tetanus oxide in the burns, prophylactic IV antibiotics for patients presenting to ER with burns, managing cyanide poisoning in suspected house fire patients, maintaining normothermia, debriding blisters more than 6 mm in diameter. There is mixed response with B, C, and A also. The answer is there is no evidence for prophylactic IV antibiotics. There is no evidence to prove that it is beneficial in burn or inhalation injuries. Rather, it increases the risk of resistant organisms and may increase the risk of fungal infections. You should seek immediate medical attention in following cases of burns, except. B. Partial thickness burns over chest. Superficial burns over forearm. Second degree burns involving any major joint. Full thickness burns involving hands or feet. Burns involving genital area. Okay. Majority of answer as B. That is right. Which formula is used for fluid resuscitation in burns patients? Portland formula, London-Roder chart, Alvarado score, Parkland formula, Winters formula. Okay. So I have understood the topic. Well, answer is D, Parkland formula. So Parkland formula is 4 ml into total body surface area of burns, this percentage of burns, into body weight. And the first half of fluid has to be administered in the first 8 hours and second half in the next 16 hours. And preferred fluid is ringer lactate. Okay. Next question, most common pathogens seen in infected burns. It's E. coli, Klebsiella species, Acinetobacter and Actinomycetes, Staph aureus and Pseudomonas, Salmonella species. Okay. The answer is D. It's right. It's a service pathogen. So most patients are infected with Staph aureus and Pseudomonas. Burn size estimation are calculated using all except rule of palms, the London-Roder chart, Snellen's chart, Wallace rule of 9. The example question to confuse. Okay, this is Snellen's chart, and this rule of 9 by Wallace. Rule of palms, as I have explained in detail. And the most accurate one is London-Roder chart. The next is the last question. Most common type of cancer encountered with long-standing deep burn scar is basal cell carcinoma, malignant melanoma, squamous cell carcinoma, multiple myeloma, lymphoma. Okay, mixed response between A and C, but the answer is C. Question is clear. This deep burn scars and it's long standing. Basal cell carcinoma is also seen, that is, but superficial burns. Okay. These are examples. These are called Marzolin cells. Okay, I have one more slide from the ETLS text. It's a modified Parkland formula. So flame was scaled. The recent update for adults and older children, 2 ml per 2 ml into weight into total body surface area of R is the ideal fluid. And coming to children less than 14, it's 3 ml, and infants and young children 3 ml RL plus a sugar containing solution at median state. But for all electrical injuries, it is same formula, 4 ml into weight into total body surface area. Thank you.
Students, do you have any questions? Please ask some questions. Sir, why did you ask that never place eyes on burns? Why did you ask that? Deepak sir, please answer.
Audible now?
Yes, sir.
Actually, placing the eyes directly onto the skin will cause intracellular crystallization and cell death. So actually what happens in frostbite and all, something like that, there will be area of cutaneous necrosis. Due to the intense cold temperature, the skin will go into permanent death. So that is another form of, like, it will cause a 3rd degree burn due to intense cold. So you should never place ice directly. And even ice water is not recommended because in children and all, if a major area is burned, what happens is if you go and pour a lot of ice water, the child can go into hypothermia. Or even if the total burn area is more than 30%, better not to pour cold water. People ask from the refrigerator, can I pour? But when you have burns or a small area or a finger, hand, etc., there is no harm in just pouring a bottle of ice water. That is fine. Cold water. Never place ice there. It's an important message.
What area of burns would you do debridement? Sujit was talking 6 mm burn also you will do debridement. Would you?
Actually, that is not a hard and fast rule. For any blister, when seen initially, a debridement of very small blisters, maybe less than 1 to 2 centimeter, is not definitely indicated for a very small blister. What happens is subsequently in the next 24 to 48 hours, it will undergo like de-roofing, and then there is chance of infection. Until the blister has been debrided or de-roofed, there is no chance of infection. Initially, it is sterile. So, if we are seeing the patient in a hospital setup, it is always better to do a debridement under a sterile condition and then give a cover dressing. Cover dressing always helps to reduce pain and also it helps in the, it provides a moist environment and there will be less chance of secondary infection also. So, open dressings are not advised nowadays. Always, even if it's a small burn, it's best to keep it covered.
Sir, what is the role of antibiotic? In which patients would you give antibiotics?
Normally, if you are seeing the patient in an acute setting, in the first 2 days, there is actually no role for antibiotic, even in a third-degree burn.
Yes, sir.
In the first 24 to 48 hours, there is definitely no role for any initial antibiotics. But in a deeper burn, like a third-degree burn, and it's an extensive area, maybe in an immunocompromised patient like a diabetic or a
With comorbidities,
patient
elderly.
has on steroids or something, we usually give a basic gram-positive cover.
Pseudomonas, then you give.
Pseudomonas is usually seen only in deep and severely infected burns. It is not seen in primarily.
Usually it is staphylococcus.
Yeah, it is staph is the most common. If you ask the most common, it is staph aureus.
In which patients would you give blood product transfusions?
That is depending. That is only
That is
indicated
not-
in extensive burns.
Yeah.
Maybe more than 30 to 40% patients. If the patient has really low hemoglobin levels,
Then only-
just to boost up his
Otherwise,
immune.
usually this ringer lactate solution.
Yeah, in the initial period, blood has actually no role. No role in the emergency management, blood doesn't have any role.
Would you give albumin?
Albin also, if indicated, is given only after like 24 hours. Initially, always with crystalloids.
Sir, have you seen in any patients with deliberate self-harm? It was so common earlier that burn the bride.
No.
Have you seen anybody like that?
That is usually when I used to work in medical colleges, government medical colleges and all, most of the like patients who present with extensive burns
Yes, sir.
are actually deliberate self-harm, young females in their
You have seen, sir?
Yeah,
It's still very common.
it's still very common in our state. But how the people choose such a bad method, I always know.
And they have survived, sir, with your treatment.
No, in most of the government medical colleges, we don't have a very excellent burn care. Burn care is still not at par. So most of them succumb to major burns, like anything more than 50%. They usually do not survive more than a week. 5 to 7 days, they usually.
So the husband is always jailed.
Most probably.
Please. What harm does applying toothpaste on superficial burns do by
Yeah,
Hannah George?
yeah. This is the most common thing that is applied as first aid in our.
Yes, sir.
Out of every 10 patients who presents to
Sir,
us.
they say coordinate
Madam, I'll just tell about even toothpaste.
Yes,
The
sir.
disadvantage tell you, toothpaste, applying toothpaste has no scientific evidence worldwide.
But every wife does that. So every housewife.
I ask most of these mothers and grandmothers
Yes, sir.
where
They
it
always
is.
do.
So it is always
So
like
that also
some
Colgate-
ancestrally somebody has
Colgate
given
toothpaste.
this and that too white toothpaste too.
Yes, sir.
Actually, it is unsterile. One.
Yes, sir.
Secondly, any form of greasy material applied over a burn wound will actually trap the heat there and adding more damage.
Yes, sir.
You understand while I explain the physiology, that transferred heat is still there. So if it has to go outside, evaporate outside, by applying a layer of oil or paste, you are actually preventing this from escaping and actually increasing the damage by trapping more heat energy. Secondly, it can cause infection because it's an unsterile meat. People say it gives some soothing feeling, etc. That is just due to the application process, you feel a slight coolness. But ideally, you are doing more harm. By that time, you have to keep on cooling and try to decrease the degree of burn. But most of our also what happens is they'll just show beneath the tap and just take it off less than a minute and then suddenly apply this either toothpaste or coordinate, then
Yes, sir.
ghee, butter, the common standard. Even egging people say. None of these are any scientific evidence to support use in first aid. Honey definitely has some anesthetic properties, but this is also as a first aid mark. So in the
Dr.
first,
Sunil, have you seen anything like that in ER? With what all people come in ER? What all do people come in ER?
Paste.
Toothpaste is a
Paste.
toothpaste is the most common thing in our state.
Toothpaste and butter is common. Honey. Sir, I think sir should give summarize. Sir, please summarize.
Yes, I think all of you have really had a very good opportunity to hear directly from the mouth of the experts regarding the pathophysiology and regarding the clinical features and the types of burns and the management. Definitely you should revise this, hear this again from the YouTube link and study this very important topic which is going to be useful for both your exams as well as for your clinical practice ahead. Thank you.
So let us conclude and wind up this wonderful academic session. Thanks to all the speakers for enlightening us, especially Dr. Deepak Aravind, Dr. Sukhjit Joseph, Dr. Abraham Matthew sir, for taking the time to explain this difficult topic in simple manner. Especially to Dr. Deepak Aravind sir for presenting so many slides on burns and explaining in depth. Special thanks to Dr. Sukhjit Joseph for the quiz. Hope all the students have got excellent take-home message from today's class. Next class is on December 5th, Saturday. So meet you on Saturday at 10 a.m. with yet another interdepartmental academic section. Wishing you all a wonderful week ahead.